Hello, in this voice-over PowerPoint, we're going to cover many drugs. We will start with protozoas, then helminths, and then ectoparasites infection. The learning objectives are one, to consider the basic principles of treatment. We're going to talk a lot about the basic principles, and then focusing on therapeutic objectives and drug selection. And we will discuss the pharmacology of some specific drugs or drug classes with some specific side effects. Let's start with malaria. You already have a session on malaria with Dr. Ghassan Awar. As a matter of fact, I borrowed this figure from his slides. I want you to remember that Plasmodium falciparum, we have a malignant form, and hence this has therapeutic implication where we might use IV therapy instead of only oral therapy. I also want you to remember that falciparum and malaria, we have no tissue forms, whereas for Ovali and Vivax, we do have tissue form, and this also has therapeutic implications. For instance, you will see with some of the drugs that we will see in the next slides that some drugs work on the tissue forms, but not on the erythrocytic form, and others work on the erythrocytic form and not on the tissue form. And if we treat only the erythrocytic form, well, we would have relapse because we would have ruptured schizons from the liver back into the blood. We would not really have any radical cure in this case. Now, just to remind you a little bit about the Plasmodium life cycle. So we start with a sporozoite from the Anopheles mosquito, and then this will go to the liver, into the hepatic cells, so the hepatocyte, and then we would have a ruptured schizont where the merozoites would be in the blood. They infect the red blood cells, and this goes into a cycle of early trophozoite followed by late trophozoite followed by the blood stage schizon, and then we'll have rupture. And this needs about 3 to 4 days, and this is why I'm sure Dr. Awar explained to you why we have fever, cycles of fever every 3 to 4 days, and that is when the red blood cells rupture. Some of the trophozoites will actually continue into gametocyte forms, and this is when the mosquito carries those gametocytes again in order to have an infection. Some important principles. We want to ask ourselves, what is the goal of the therapy? Are we aiming for only clinical cure, meaning that we want to treat the acute attack, the fever that happens every 3 to 4 days, the erythrocytic form? Are we aiming for radical cure? What I mean here is prevention of relapse, and hence in this case we really want to get rid of the hypnozoites in the liver. This usually happens after we leave the endemic area, because once we are in the endemic area, we are bound to be reinfected. Are we aiming only for suppressive therapy, meaning that we don't want to have an acute attack every now and then? We want to make sure that we don't have any blood forms, although we may have tissue forms sitting there. Are we aiming for causal prophylaxis? And here I want to differentiate causal prophylaxis from chemoprophylaxis. Chemoprophylaxis is when, for instance, we are planning to travel for a short while to an endemic area. There are several protocols depending on the resistance, depending on the patient, and we may take drugs before, during, and after so that we prevent infection, hopefully. This is not causal prophylaxis. Causal prophylaxis, the definition is prevention of infection using drugs that act on the primary hepatic form. I want to really tackle the primary hepatic form. And then we have prevention of transmission to mosquito. How do we do that? By having drugs that work on the gametocytes, and this is good because it helps in decreasing the spread of the disease. So how do we choose the drugs? 1, depending on the goal of therapy, as listed above. 2, depending on the resistance patterns, of course. And 3, depending on some pharmacokinetic properties. For instance, we mentioned that Plasmodium falciparum could be very malignant, and in severe attacks we may give IV quinidine. Also, chloroquine is given once a week for chemoprophylaxis. Again, that depends on if we are in areas where we have non-resistant parasites. I'm sure Dr. Awar gave you protocols for chemoprophylaxis, and I don't think that chloroquine is first line. I think Malarone is first line, but it doesn't matter. The point here is about pharmacokinetics. Chloroquine, the nice thing about it is that it can be given once a week, and this is important for compliance. In this table, I show on the left some of the drugs that are given for malarial infection, and we're going to talk about the mechanism of action in a while. But here I'm differentiating them into groups based on when can we use them, what goal. For instance, the first group, artemisinin, chloroquine, mefloquine, quinidine, pyrimethamine, sulfadoxine, and tetracycline. Those are useful for clinical cure and suppressive therapy. Why? Because as you can see, they really work nicely on the blood stage, on the erythrocytic form. None of them is useful for the liver stage. In contrast, atovaquone proguanil works on both, on the liver stage and on the blood stage, although it works much better on the liver stage. And primaquine is useful for radical cure. Why? Because it also works on the hypnozoites, the liver stage hypnozoite, where we are done, both primary and hypnozoite. Usually when we treat malaria, it's very possible that we give a combination of drugs, because some would work on the liver, some would work on the blood, some would work on the gametocyte, so that we have a better treatment. Now we're going to go over the anti-malarial drugs. So we have the quinolines and the related compounds. We have artemisinin and derivatives, pyrimethamine, and atovaquone proguanil. We will start with the quinolines and the related compounds. How do they work? Well, it's shown in this figure below. So, as you see, when the parasite is inside the red blood cell, well, it digests the hemoglobin to obtain essential amino acids. And once it does that, you would have a release of heme. But this accumulated heme is very toxic to the parasite. So what it has an enzyme called heme polymerase, and that heme polymerase really polymerizes heme into hemozoin so that it's not toxic to the parasite anymore. In the presence of chloroquine, which is one of the quinolines, this enzyme is inhibited, and hence, instead of having hemozoin, we're going to have accumulated heme, which will lead to lysis of the parasite, and hence death of the parasite. What are those quinolines? We have quinine and quinidine, and as a matter of fact, they are optical isomers. Therapeutic use, we already know that they are antimalarial. Also, they are less effective than other drugs, such as chloroquine. In the past, they used to use them as analgesic antipyretics. Now, obviously, we have better drugs, such as acetaminophen. And also in the past, they used to use them for their curare-like effect on muscles. They lead to muscle relaxation. And this is very useful in myostonia congenita and nocturnal leg cramps that are very, very, very painful. But of course, now we don't use them anymore because of their toxicity that we will see in the next slide. So toxicity, one is synchonism. Synchonism, this word is coming from the tree, cinchona tree. And this is dose related, and those are the central nervous system side effects. So one can have headache, visual, auditory disturbances, nausea, and extreme cases vomiting. Those drugs are contraindicated in myasthenia gravis, obviously. At very high doses, they might lead to hypoglycemia and hypotension, and on chronic uses, we may have hearing loss, which is problematic, of course. Chloroquine, we are in the same classes of drugs, same mechanism of action. Of course, we know it is antimalarial. It used to be used for hepatic amoebiasis, but now we have metronidazole that is much better, and we will see it in a couple of slides now. It's given at high doses as an anti-inflammatory for rheumatoid arthritis and lupus. We already mentioned a pharmacokinetic property for chloroquine is that it has a long half-life, so it can be given once a week. However, now we have a problem with chloroquine, and that is resistance. And the mechanism is that the parasites do not accumulate chloroquine to a lethal amount. Toxicity at regular doses is usually safe, At higher anti-inflammatory doses, we may have GI disturbance, rashes, headache, QT prolongation, retinal injury, and nerve deafness. And when you go to the OPD in Med3 and you start seeing patients with rheumatoid arthritis or lupus taking chloroquine, you will see that they have to check their eyes at the ophthalmologist every now and then to check for retinal injury. Next is primaquine. Primaquine, same mechanism of action like the others, inhibiting the heme polymerase, but also it acts as an oxidant. And because of that, it is associated with hemolysis and G6PD deficiency. So we have to be careful with patients who have G6PD deficiency, and as a matter of fact, it's better to screen for that before we start primaquine. Finally, for mefloquine, the problem is that it may also cause QT prolongation, so one has to be careful in patients taking drugs that may also cause QT prolongation. Central nervous system disturbance such as vertigo, confusion, psychosis, seizure, and this is contraindicated in patients who have acute or recent depression. And you may already know that mefloquine may be used for chemoprophylaxis, and we have to be careful and screen whether the patient has depression. In this case, we cannot give mefloquine. Also, there's a problem with CYP drug-drug interactions. Now we move to another class of drugs, and that is artemisinin and derivatives. And the drug here is coartem, which is actually a combination of artemether and lumefantrine. Lumefantrine works like chloroquine, whereas artemether kills by releasing free radicals. The source for artemether is the Artemisia annua plant. Why do we have them together? Because of a very nice synergism. For instance, for artemether, the kill requires a high concentration of iron, which we would find with lumefantrine. This drug is excellent for severe Plasmodium falciparum, among others. It's also used for chemoprophylaxis, I believe. The risk is CYP drug-drug interaction and again QT prolongation. Next is pyrimethamine. It works like trimethoprim. We've seen this drug together before as an antifolate drug. It inhibits dihydrofolate reductase. And as a matter of fact, you will see it in combination with sulfonamides. For instance, the drug Fansidar is pyrimethamine and sulfadoxine. And as you would know, we have a risk of megaloblastic anemia in prolonged use. Finally is atovaquone and proguanil. Atovaquone disrupts mitochondrial electron transfer, whereas proguanil, it acts like pyrimethamine, and toxicity is GI upset acutely. Chronically, we may have folic acid deficiency. We're done with malaria. Now we're going to move to other protozoal infections. In this table, I summarize for you some important protozoal diseases with the causative agent. Of course, by now you know them by heart. And on the right, we have the drugs of choice. I highlight in green the ones that we're going to cover. Actually, we already talked about chloroquine, we already talked about pyrimethamine, and the drugs that we will talk about in the coming slides are iodoquinol, paromomycin, metronidazole. I'll not talk about tinidazole, but it's very similar to metronidazole. I want you to realize that although there are some drugs that are given for several protozoal diseases, but of course the dose of the drug and the duration of the drug would be very different. And actually I've uploaded on Moodle a medical letter document for your curiosity, of course not for your memory, showing the drugs that are used for each disease and what are the doses and the duration. First, we will talk about amoebiasis. And remember, the aim of this voice over PowerPoint, one of the main aim is to talk about the principles of therapy. So let us go over this figure showing the life cycle of Entamoeba histolytica and discuss few things. So we start with the ingestion of the cyst, then formation of the trophozoites, and then the trophozoites are going to penetrate the intestinal wall, go into the blood, and infect the liver. Why is this important? And of course, we're going to have some cysts going into the feces. Why is this important? The important thing is to know that with amoeba, you would have the colonic form and the tissue form. And usually we assume that if a patient has cyst, most probably the patient also has systemic amoebiasis. And hence we have to treat both forms. We have the luminal amoebicides, and that is paromomycin and iodoquinol, and those would work in the colon on the cyst. And we also have systemic ones, and that is chloroquine, metronidazole, and tinidazole. Now we don't use chloroquine much because we have metronidazole and tinidazole. In conclusion, when we have amoebiasis, we want to give a combination therapy of luminal amoebicides and systemic amoebicides. Now, by the way, metronidazole and tinidazole will work on the luminal ones, but they are very well absorbed, and hence they would not concentrate much in the colon to kill the cyst. This is why, although they can work, we really need the luminal amoebicides with them. What are select drugs for protozoal infections? For all of them, not just amoebiasis in this case: iodoquinol, paromomycin, metronidazole, and of course we have others, some of which are listed in the tables, but I have 2 slides on those, not for your memory, just for completion. To start with iodoquinol, we have unclear mechanism of action. We have very little systemic absorption, so we find them in the colon, and this is where they would work on the amoeba, for instance. If absorbed, we would have rash. Of course, we might have diarrhea. And if absorbed, we may have optic neuritis and permanent loss of vision with prolonged treatment. Next is paromomycin. This is actually an aminoglycoside. I'm sure you remember how aminoglycosides works as ribosomal inhibitors. Again, we have very little absorption, and hence in the case of amoeba, they would work on the colonic form. With paromomycin, we may have mild GI distress and diarrhea. Next is metronidazole. We got very excited when it was introduced in 1960s because metronidazole is good for many protozoal infections, but also good for anaerobic bacteria. How does it work? It's a prodrug. It needs to be activated into a reactive hydroxylamine, and to do that, it really competes with the electron transport protein ferredoxin. And the active metabolite, and that is the hydroxylamine, ultimately is cytotoxic because it fragments DNA, and hence it inhibits further nucleic acid synthesis. It is selective for anaerobic parasites and bacteria. Why? Because we need the electron transport proteins ferredoxin. And also why in only anaerobic parasites and bacteria? Because oxygen would inhibit cytotoxicity of metronidazole by removing the electrons from the active form. We do have some resistance to metronidazole in anaerobic bacteria and parasites, but luckily not much with Entamoeba histolytica. How do we have resistance? The most common mechanisms are decreased synthesis of ferredoxin, increased local oxygen concentration, and among other mechanisms that are also there. Pharmacokinetics. I mentioned already that it is very readily absorbed, and hence we have very low concentration in the colon to kill the cyst. It could kill the cyst, but we don't use it for that purpose. It penetrates all tissues, and hence this is why we like it to kill parasites in the colonic wall as well as in the extraintestinal sites. It is metabolized by the liver, by CYP enzymes, so one has to be careful. There's a potential for drug-drug interactions, and also if a patient is taking inducers such as phenobarbital, one has to be careful, or patients taking inhibitors such as cimetidine, among others, of course. Toxicity. GI disturbance, the patient would tell you that they have like a metallic taste or glossitis. Neurotoxic effects are very rare but can occur. One can tell you I have a severe headache, for example. Disulfiram-like effect, we talked about this before, and there is also the potential for teratogenesis. In this slide, I list some of the other drugs used for protozoal infections for your curiosity and for completion, but not for your memory in this slide and in that slide as well. Next, we shift to parasitic worms. In this table, I summarize also some of the worm classes, the common names and the official names. I'm sure that by now you know them by heart also. And I also list the drugs of choice. And I don't want you to remember for which worm we give which drug. It's just here for completion. I wrote down albendazole in 1990. Also, we're very excited that we have albendazole and the similar drugs because those are very useful to treat helminth infections. And we're going to have only 2 slides on the drugs for helminth infections, so we're going to focus on the generalities. Here we have the mechanism of action. So we have a group of drugs, the benzimidazole, basically albendazole, mebendazole, and triclabendazole. I'm sure you've heard before of Zental and Vermox. The mechanism of action here is inhibition of microtubule polymerization by binding to beta-tubulin. Then we have those that act by muscle paralysis via different mechanisms. We have ivermectin, pyrantel pamoate, praziquantel, and levamisole. The most important thing that I want you to remember here is that muscle paralysis is not lethal. So benzimidazole, they are lethal. Niclosamide, diethylcarbamazine are lethal. Whereas those that act by muscle paralysis are not lethal. That means that with those non-lethal drugs, you have to prescribe a purge, something that leads to severe diarrhea, so that all the worms are expelled. Otherwise, they stay in the intestine, they're paralyzed, but they're not dead. And once the effect of the drug is over, they are alive to duplicate, etc. So for the others, you may not need to take a purge, although using a purge may also be useful so that you get rid of those worms really quickly. And sometimes you don't want big dead worms in your intestine. But for those that only lead to muscle paralysis, you absolutely need a purge, otherwise you haven't done anything. General adverse effects. We really have little systemic adverse effects, especially for the benzimidazole because they are and pyrantel pamoate because they are poorly absorbed. We may have transient abdominal pain, distension, and diarrhea in cases of massive infection and expulsion of the GI worms. This may happen. And we have some specific side effects such as the Mazotti reaction due to dying microfilaria with ivermectin, and the reaction is described in the slide. Finally, we move to the treatment of ectoparasites. What are ectoparasites? Basically, lice and mites. The basic principles for the treatment of ectoparasites, what we want here is topical treatment. We want creams, gels, lotions, liquids, and shampoos. They are associated with very little systemic absorption, so they are relatively safe. Ivermectin is the only oral drug. And some principle for lice, we really need 2 applications. So once is not enough. We apply the shampoo today and then we have to repeat the shampoo in 7 to 9 days. And it's also not enough for the ova to be removed from the hair. We have to use the special combs so we get rid of the ova. This table summarizes some of the topical drugs of choice for mites and lice. We have the generic name and the mechanism of action is written here. I want you to remember which ones are for lice and which ones are for mites, and which ones kill the ova and which ones do not kill the ova. I put here the minimum age and weight for use because one has to be careful. Some drugs are not approved for very young children, others they are. And concerning the adverse effects, if you read them, you can tell that most of them are really burning and stinging and itching and numbness, things that if the drug touches the eye. So once we use those shampoos, for example, on the scalp, we have to be careful not to touch the eye. One thing with malathion, because it has alcohol in it, so you want to tell your patient not to use the séchoir after the shower because there's a risk of burn because of the alcohol. Lindane, rarely we may have systemic absorption and convulsion.